بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullah, everyone. Ramadan Mubarak. Good evening or good day, wherever you are. It's my distinct pleasure to welcome you all to the first webinar of 2025, hosted under the IVPN-Critical Care Listserv for this year. And as the leader of this vibrant listserv, I am thrilled to see our commitment to advancing critical care pharmacy practice continuing to grow. Together, today we are a gathering of more than 250 delegates who gather to explore a topic of paramount importance, the power of antimicrobial therapeutic drug monitoring in critically ill patients. So in critical care, where every decision can be life-saving, optimizing antimicrobial therapy through therapeutic drug monitoring, in short, TDM, is essential for improving outcomes and combating resistance. We are honored to have with us tonight an esteemed expert and dear friend in the field, Dr. Nada Al-Khani, who is a distinguished consultant, critical care clinical pharmacist, a highly accomplished clinical pharmacist with board certifications in both general pharmacotherapy and critical care. Dr. Nada holds the Doctor of Pharmacy degree from the Massachusetts College of Pharmacy and Health Sciences in Boston, US, and she completed the prestigious ASHP accredited pharmacy residency training at Brigham and Women's Hospital, and then at the University of Arizona, PGY1 and PGY2. Also, Dr. Al-Khani has held various leadership positions throughout her career, including being a board member of the Critical Care Pharmacy Specialty Network, PSN, within the Saudi Society of Clinical Pharmacy, SCCP. Finally, Dr. Nada is actively involved in research, teaching, and professional organizations. I encourage you all to engage actively, ask questions, and take this opportunity to deepen your understanding of antimicrobial TDM in the ICU. Without further delay, please join me in welcoming Dr. Nada to the stage. Thank you, Dr. Nada, for being with us. The floor and mic and screen is all yours.
Thank you so much, Dr. Ahmed, for the invite to present at the IVPN network this night. It would be a pleasure for me to present about the therapeutic drug monitoring in ICU patients. So I'll start by sharing my screen. Is it clear?
Yes, very good.
Okay, so today we'll be discussing the power of antimicrobial therapeutic drug monitoring in ICU patients. So during our presentation today, we will review the general pharmacokinetic and pharmacodynamic principles in ICU patients through explaining its essential role in optimizing antimicrobial dosing for critically ill patients and demonstrating the evidence supporting its clinical benefit. So generally, effective treatment of sepsis depends or demands prompt administration of appropriate antimicrobial that require precise dosing to enhance the likelihood of patient survival. And when we are talking about adequate dosing, we are referring to the administration of doses that yield therapeutic drug monitoring or therapeutic drug concentration at the infection site, to ensure a favorable clinical and microbiological response while avoiding antibiotic-related toxicity. And when we're talking about therapeutic drug monitoring in ICU patient, we are referring to those patient population who needs this special attention while dosing medication, like pediatrics, pregnancy, geriatrics, cystic fibrosis patient, obese, burn, dialysis, ECMO, as well as immunocompromised patients who need this extra look or extra attention when we look into their pharmacokinetic and pharmacodynamic properties. So when we're thinking about pharmacokinetic relationship, we're actually looking into how much dosing we're giving to get the effect we want. So we're looking into the dose-effect relationship. When we are giving the appropriate dose, we are looking into the drug concentration in the blood. that also lead to an appropriate drug concentration at the target site, which we called pharmacokinetic, which is the impact of the body on administered drug. Then this specific drug concentration at the target site will exert the effect to give the clinical outcome we are looking for, which we refer to as pharmacodynamics, which is the impact of the drug on administered body. So what are the different challenges of antimicrobial therapy in ICU patients? There is actually multiple challenges, and those are just a simple four specific challenges. For example, the pathophysiological changes that could happen in ICU patients that's altering the absorption, distribution, metabolism, and elimination, affecting both hydrophilic and also lipophilic drugs. The organ dysfunction, so most of our patients have liver and renal impairments that lead to reduced drug clearance and metabolism, which necessitate the drug dose adjustment. Also the fluid shift. We all know that there is increased vascular permeability and edema that expands the volume of distribution on those patients, which specifically affect hydrophilic drugs. Also drug protein binding, especially with hypoalbuminemia, that increases the fraction of unbound drugs, potentially lead to subtherapeutic concentration of those drugs. So what are the different kinetic changes that we can expect that affecting the administration, distribution, metabolism, and elimination of the drug? So there is multiple organs involved in this alteration. For example, the liver. Any liver injury or dysfunction can affect the cytochrome P450 metabolism, blood flow to the liver, as well as protein binding, changing in respiratory function and respiratory failure that causing acidosis and alkalosis can also affect pharmacokinetic of the drug, losing muscle and rhabdomyolysis, as well as endothelial failure, which increases the total body water or volume, or altering serum protein levels, the endocrine distress or dysfunction, cardiovascular failure, which is very much affecting the drug absorption and decrease the perfusion, renal failure, which exert a decrease in function of renal function and fluid retention, CNS, as well as GI failure, which very much affecting the absorption of the enteral drugs, and also changes in pH. So what are the pharmacokinetic consideration upon administration and the absorption of the drug? First of all, the delayed gastric emptying is affecting the absorption of those drugs, especially we're using vasopressors in shock, so we are reducing the blood flow to the GI, and also we're using feeding tubes while administering those drugs. So we should think about the different effect of those tubes and absorption that can happen while administering the drugs through those tubes. In terms of distribution, the changes in protein binding and fluid shift, particularly for highly protein-bound drugs, and the capillary leak. So we are thinking about a lot of interstitial fluid, and also we're giving a huge amount of fluid resuscitation that's increasing also the fluid and interstitial fluid in the patient body. Going to metabolism, so drugs that needs to be metabolized through cytochrome P450 enzyme may also be reduced, and also affecting hepatic drug metabolism and drug-drug interaction. For excretion, renal elimination is a huge problem in ICU patients. In terms of patients who would have acute kidney injury or augmented renal function, or also those patients who would need renal replacement therapy. So what are the key physiological changes in ICU patients that we need to focus on? The volume of distribution, the drug clearance, and also the tissue penetration. Also, we need to look at the different modalities that our patient would be using during ICU stay that would also affect the drug pharmacokinetic in those patients, which is the ECMO, the extracorporeal membrane oxygenation, because ECMO can lead to drug sequestration and alteration in volume of distribution. Also, continuous or prolonged infusion may be necessary to maintain therapeutic concentration in those patients who are on ECMO. Also, CRRT patients who are on continuous renal replacement therapy will have alteration in drug clearance that's affected by the effluent rate of the CRRT as well as the membrane characteristic. So individualized dosing adjustment is very important in patients who are on CRRT. So let's think about therapeutic drug monitoring in ICU. What are the 4 pillars in applying therapeutic drug monitoring in those patients? What are the things that we have to look at to have a successful therapeutic drug monitoring? So number 1, we need to understand our patient. We need to know the characteristic for our patient. We need to look into those different organ function, what's affected, what dysfunction the patient is having, the disease severity, and the body composition. The different drugs that we are administering, the pharmacokinetic profile and protein binding for lipophilic versus hydrophilic drugs, implementation of therapeutic drug monitoring in terms of having the service available, having rapid sample collection and analysis, and lastly, having an expert who can interpret the result and act accordingly based on those results. So based on the different characteristic of antibiotics we are using, we can look into the differences that can happen in terms of having a critically ill patients in using those medication. So in hydrophilic drugs or hydrophilic antibiotics, we can see that those antibiotics have small volume of distribution that can be increased in critically ill patients. Also, they are cleared renally. However, in critically ill patient, we should expect that renal function can increase or decrease. So its clearance can be affected either by increase or decrease. Also, for distribution, those has a very poor intracellular penetration, but actually it's decreased in critically ill patients. And those are some examples for hydrophilic antibiotics like beta-lactam, aminoglycosides, glycopeptides, colistin, daptomycin, and the fluconazole, which are very much the most antibiotic that we are using in our ICUs. Lipophilic antibiotics have a large volume of distribution that does not really change in ICU patients. It can be cleared dominantly through hepatic clearance, which also can be affected by it to be increased or decreased based on hepatic function in the ICU patient. The distribution, usually it's good in general population and does not change dramatically in ICU patients. And when we are talking about lipophilic antibiotics, we're talking about fluoroquinolone, macrolide, tigecycline, clindamycin, linezolid, voriconazole, and posaconazole. So it is challenging to dose lipophilic antibiotics in ICU, but it's not as challenging as hydrophilic antibiotics. So what are some of the solutions that we can throw and try to examine while dosing antibiotics in ICU patients? Some of the solutions or modalities is to use high loading doses, and this is also suggested in hydrophilic drugs to achieve therapeutic drug concentration due to increased volume of distribution. Optimizing dosing regimen using some models or different modalities, for example, like the modalities of vancomycin dosing to determine effective dosing strategy. The last or one more solution is to use continuous versus intermittent infusion, especially in beta-lactams or hydrophilic drugs, to attain appropriate pharmacokinetic pharmacodynamics in those patients. So let's start by looking into the data behind beta-lactam antibiotics dosing. So beta-lactams are time-dependent killing. We're talking about pharmacokinetic pharmacodynamic index to reach 100% of drug concentration, 100% of the time above the MIC. Clinical data from critically ill patients suggested that the benefit for longer duration of free drug 100% above MIC and a higher concentration above the MIC by 2 to 5 times of beta-lactam exposure than those previously described in preclinical studies. Beta-lactams generally are wide therapeutic index, so there is no readily available therapeutic drug monitoring needed, and high exposures has been associated with neurotoxicity, especially when we're talking about cefepime, fluconazole, carbamazepines in general, and piperacillin tazobactam. So what is the modalities that has been studied in beta-lactam to see how can we improve or we can optimize drug therapy in those agents? So there is a study, 2 studies actually, that has been published in 2023 to examine the continuous versus intermittent administration of beta-lactam. And here we have MERCY's trial, which is a double-blind randomized clinical trial that looked into continuous versus intermittent meropenem administration in critically ill patients. And in this study, they looked into the administration of continuous administration of 3 grams meropenem over 24 hours versus intermittent administration of 1 gram meropenem over 30 minutes every 8 hours in 31 different ICUs worldwide, to look into all-cause mortality and the emergence of pan-drug resistance or extensively drug-resistant bacteria at day 28. And interestingly, they found that there is no statistical significant difference between continuous infusion versus intermittent infusion, with a 47% of mortality or composite primary outcome at day 28 with continuous infusion and 49% with intermittent infusion. Then BLINK-3 randomized clinical trial was published when it looked into the continuous versus intermittent beta-lactam antibiotic infusion in critically ill patient. Here they used piperacillin tazobactam or meropenem over 24 hours versus intermittent infusion over 30 minutes of either piperacillin tazobactam or meropenem. And they looked into all-cause mortality within 90 days after randomization. And very much similar to this trial of MERCY, very much similar to the results of MERCY trial, they found that the all-cause mortality at day 90 was 24.9% for continuous infusion versus 26.8% in intermittent infusion. Lastly, Dr. Abdulaziz and his colleague published a meta-analysis for prolonged versus intermittent infusion of beta-lactam antibiotics in adults with sepsis or septic shock. And they included 18 randomized clinical trial that includes around like 9,000 critically ill patients with sepsis or septic shock, and looked into all-cause mortality at 90 days. And they found that there is actually a good benefit of using prolonged infusion in terms of all-cause mortality with 0.86 estimated risk ratio for prolonged infusion, with a 99.1 posterior probability when using prolonged infusion with associated lower 90 days mortality. And also they found 0.84 risk ratio for prolonged ICU mortality with prolonged infusion, and also 1.16 risk ratio of increased clinical cure with prolonged infusion, which has a very promising results in terms of using prolonged infusion, not continuous, as previous trial did not really support the continuous administration of those of beta-lactam. And if you can see here, that the two antibiotics that have been studied or in those trials in this meta-analysis were 10 for meropenem and 7 for piperacillin tazobactam. And you can see here from the graph that for primary outcome all-cause 90-day mortality, very much favoring the prolonged infusion. Also, if we look into the sub-analysis for meropenem and piperacillin, both also favor prolonged infusion. Similar, if we can look into the microbiological infection, kidney renal replacement therapy, the different site of infection in lung or other sites, sepsis versus septic shock, and also when we are looking into the secondary outcome in terms of ICU mortality or adverse effect. For secondary outcome, for clinical cure or microbiological cure, also favors prolonged infusion as well as ICU length of stay. So the result of this study was very promising when we're talking about intermittent infusion for meropenem and piperacillin tazobactam. But for everyone who's working in the ICU on a day-to-day basis, you can see that we have very much emergence of pan-resistant and drug-resistant Pseudomonas gram-negative bacteria, which lead us to use the new beta-lactamase inhibitor combination. For example, like ceftalozone tazobactam, ceftazidime avibactam, and the other combinations that we're using now more frequently. And here we always stop to think, what would be the appropriate adjustment that we should apply for our ICU patients? Actually, there is no clinical trials published to examine the appropriate administration or dosing in those drugs, especially when we're talking about prolonged versus intermittent infusion. But actually, the best way to do is to look into the different factors that can affect those drug pharmacokinetic, pharmacodynamic. So if you can see, very much similar to the beta-lactam, they all get affected by renal function. They have a variability in protein binding between 20% to like around 50%. And the pharmacokinetic, pharmacodynamic target is between also 30 to around like 75% of the time above the MIC. So optimizing those drugs should be like by looking into the simple pharmacokinetic properties, but for sure, this is a huge area for research to look into the appropriate dosing in those new beta-lactamase. Moving to vancomycin, which is also a hydrophilic, has a poor lung and CNS penetration. It has a small volume of distribution in general patient population and predominantly cleared through renal system. In a critically ill patient, we can see that it is associated with increased in volume of distribution and the clearance, leading to variable and low drug exposure. So it's a time-dependent bacterial kill. Some data also demonstrated that Cmax over MIC ratio to be equally important as well. So it is, to me, when I think about vancomycin, it is very much time dependent and also has a lot of concentration dependence killing as well. The pharmacokinetic pharmacodynamic index very much depends on AUC over MIC to be more than or equal to 400. And this is very much recommended to target against Staphylococcus aureus, MRSA. Higher exposure are probably needed when treating critically ill patient with septic shock, endocarditis, or even CNS infection. Prolonged 7 days or more and high vancomycin exposure can commonly be associated with nephrotoxicity, which is the major adverse effect of vancomycin that we are always trying to avoid when using vancomycin. There is a systematic review and meta-analysis concluded that vancomycin therapeutic drug monitoring significantly increases the rate of efficacy and decreases the rate of nephrotoxicity in patients receiving vancomycin. Cardial and his colleague looked into the therapeutic drug monitoring on the trough levels, resulted in faster target concentration attainment and more rapid discharge from the hospital, clinical stability, and short courses of vancomycin. And this is very much what we have been used over the years, is to monitor trough levels of vancomycin with a target between 15 to 20. Then Neely and his colleague also looked into the AUC versus trough-based therapeutic drug monitoring, and they found that AUC therapeutic drug monitoring was superior with regard to reduction of nephrotoxicity as well as shorter therapy time. And now the data is very much moving forward or moving toward AUC therapeutic drug monitoring models in vancomycin. Colistin, interesting drug that we are using very much with XDR and multi-drug resistant bacteria, but also it has a very unique pharmacokinetic. It is a concentration dependent killer antibiotic. It has a very narrow therapeutic drug index, which make it even more complex when doing therapeutic drug monitoring. It has around like 59 to 74% protein binding, and the elimination via several route, renal elimination, is what really plays the main role in clearing colistin in those patients. Why it has a unique pharmacokinetic? Because actually, when we think about colistin, we should think about it as an inactive prodrug of alcolistimate sodium that undergoes complex transformation before reaching its active form. Significant inter- and intra-individual variability in colistin pharmacokinetic lead to inconsistent plasma concentration despite identical drug dosing. So even when we are giving the same drug dosing, this prodrug is leading to variable drug concentration or active drug concentration, because the conversion itself will very much be affected by renal function. So renal function will affect the conversion from inactive to active, and then it will affect the clearance of active drug. So in patients with creatinine clearance of 120, this is just some examples. In patients with creatinine clearance of 120 ml per minute, there will be increase in the conversion by 33%. And also there is an increase by 50% in creatinine clearance of 50 ml and increase by 67% in creatinine clearance of 25 ml per minute. So that's very much brought us to the different pharmacokinetic and dosing of colistin that's very much used to MDR, XDR, Pseudomonas, and Acinetobacter baumannii. The drug dosing of colistin depends very much on administering a huge or a big loading dose of 9 million units, followed by the maintenance dose, which is around like 4.5 million units every 12 hours. It is affected by renal function using renal replacement therapy in those patients. Also, it has 14% protein bind. We very much rely on AUC over the MIC, and there is a lot of recommendation about using therapeutic drug monitoring with colistin. So how much we can use therapeutic drug monitoring, or what's the data of using therapeutic drug monitoring with colistin? So Sorley and his colleague found that a total trough levels above 2.4 milligram per liter is associated with nephrotoxicity. Also, trough levels of colistin are suggested to be approximately 2 milligram per liter as an optimum between efficacy and nephrotoxicity. And also the result of a recent review that included 7 manuscripts describing therapeutic drug monitoring and clinical efficacy with nephrotoxicity is very much contradictory. It does not very much having a conclusive recommendation of using therapeutic drug monitoring for colistin. So actually, even that therapeutic drug monitoring could be essential, but it's not really available widely due to the complex sample collection, handling, and analysis. And to tell you the truth, during my practice, I've never done a therapeutic drug monitoring while using colistin. Although I believe it would be an interesting way to also dose colistin, especially in a patient with poor renal function. So let's think about therapeutic drug monitoring process in general. And here is a study that has been published by Takahashi and his colleague in 2023 that evaluating therapeutic drug monitoring for antibiotic optimization in critically ill. It was a comprehensive systematic review and meta-analysis that included 5 different randomized clinical trials with around 1,000 patients that evaluate the effectiveness of therapeutic drug monitoring-based regimen in ICU patients, which looked into the 28 days mortality and also different secondary outcomes, including in-hospital mortality, clinical cure, ICU length of stay, and target attainment at day 1 and 3. And the results was very much of 26.9% of 28 days mortality in patients who were receiving therapeutic drug monitoring-based dosing, with 28% in standard dosing. So there was no significant difference between therapeutic drug monitoring and standard dosing, which is interesting. Also, when they looked into the secondary outcome, there was also no much difference in terms of in-hospital mortality, clinical cure, ICU length of stay, or target attainment. Those are the different 5 trials that was included in the meta-analysis. If you can see from the trials, the drugs that or the antibiotics that was used is aminoglycoside, piperacillin, tazobactam, beta-lactam, Cipro, piperacillin, tazo as a continuous infusion, and also vancomycin, Cipro, meropenem, and ceftriaxone. So in conclusion, although there was no significant benefit found in using therapeutic drug monitoring-based antimicrobial or antibiotic regimen that has shown improvement in 28 days mortality in hospital mortality, clinical cure, or target attainment, but actually there is a need for further research because while there's no clear benefit, but a more well-designed randomized clinical trial focusing on specific patient population is very much needed, and looking into more detailed information about the dosing that has been used in those antimicrobials. So let's think about general role of using drug dosing optimization in ICU patients. So we need to look into the drugs or the property of the drug that we are administering when we're talking about hydrophilic versus lipophilic drugs. In hydrophilic drugs, it is always encouraged to start with increased loading dose at the initial phase between 0 to 24 hours of admission. So high loading dose before clearance for time-dependent drugs. Then we can consider prolonged or continuous, but the data is more favoring prolonged infusion for time-dependent drugs. And then we can adjust the drug dosing based on creatinine clearance, augmented renal clearance, or extended drug dosing for concentration-dependent drugs. Then in late maintenance phase, which is after 48 hours of drug therapy, we can always adjust the drug dosing to renal function using maybe renal replacement therapy, and also the residual renal function. In terms of lipophilic drug, at the initial or the early initial phase, weight-based loading dose is essential, and we have to look into consideration to our patient population, especially when we're talking about obese patients. Then in early maintenance phase, we can adjust the drug dosing according to hepatic function, and looking into the severe cirrhosis as well. In late maintenance phase, which is more than 48 hours, we can adjust drug dosing to hepatic function. And if they have been using any like different modalities like ECMO, when we are thinking about drug sequestering of those lipophilic drugs in the tubes of ECMO machine. Anyways, in all drugs, we have to use therapeutic drug monitor whenever available and consider dosing nomograms. And then we can adjust based on recommendation, therapeutic drug monitoring, dosing software, and also looking into the MIC results of the microbiology result as well. The good thing about ICU dosing that there is technology advancement in therapeutic drug monitoring. So now we can see there is more point of care testing that can develop a rapid and bedside drug concentration analysis. There is a lot of pharmacokinetic modeling in terms of implementing a model-informed precise dosing using, for example, the Bayesian method for vancomycin dosing. And hopefully in the future, we should see more artificial intelligence integration and also different drug dosing and optimizing dosing regimen in real time. So what's our role as a pharmacist to lead therapeutic drug monitoring service? Number one, we are the experts. So we are experts in pharmacokinetics, especially when it comes into critical care patients, and we can help in optimizing drug dosing regimen. Also, interdisciplinary collaboration is essential by enhancing the communication between pharmacists, intensivists, and other healthcare providers, especially nurses. Educational initiatives and having a lot of educational sessions and training to healthcare staff is very important to implement and interpret therapeutic drug monitoring data. With this, I would like to thank you all for your kind listening. Those actually the references that I looked at while preparing this presentation. And I would open the floor for any questions.
Thank you very much, Dr. Nada. Impressive presentation by all means. World-class speaker. I really appreciate all the valuable knowledge you shared with us. It's really a mixture of solid evidence, trials, summaries, pearls also for everyone who is practicing in the hospital and dealing with ICU patients. So thank you so much for this valuable knowledge and expertise you shared with us. So I see we have tens of questions, mashallah, in the chat, and I'll try to, as much as possible, to cover most of them. So this really reflects the strong interest of people in this very important topic. Yeah. So I'll start with one question from. One second, let's see here. Yeah, from Mervan Rashid. So she's asking, or he is asking, okay, how does CNS diseases or disturbances affect the pharmacokinetic of drugs?
A great question. And this is something we deal with very much a lot, especially in neuro ICU patients and patients with meningitis. So the physiology of CNS or the central nervous system is protected by blood-brain barrier, which very much reduces the drug delivery to the CNS, to the brain, because of this blood-brain barrier that will only allow lipophilic drug to pass and to reach the CNS and the brain. So when we're having meningitis or CNS infection, we need to look into the appropriate dosing which needs a higher doses to reach the appropriate concentration of the drug at the infected site. So whenever we're having a CNS infection, we should consider higher doses and more specific meningeal dosing in term, especially with lipophilic drug. So for example, if we're using 1 gram Q8 hours for meropenem for pneumonia in CNS infection, we need to double like 2 grams Q8 hours. Even with vancomycin, there is some recommendation to use a higher trough level with vancomycin, but still the data here is very much controversial of using like 15 to 20 versus 20 to 25 whenever we're having a CNS infection with MRSA. But yeah, higher doses and optimized drug dosing is very important with CNS infections.
Absolutely. Thank you very much, Dr. Nada. So yeah, as we always see in meningitis, we always meningitis always like also endocarditis. So those they always have some special dosing that is usually higher than the other indications. Excellent. So moving to another question from Sana Sheikh. So she's asking, when we talk about prolonged versus intermittent versus continuous, is there like a cutoff? How many hours do we say prolonged or continuous infusion?
Okay, so when we're talking about the modality of drug dosing in those agents, we're talking about 3 different modalities: the prolonged infusion, intermittent, continuous, prolonged, intermittent, or prolonged or intermittent. For intermittent, we're talking about like 30 minutes. With continuous, it's 24 hours. With prolonged, most of the data is suggesting 3 to 4 hours. I looked at this in meropenem, ceftazidime, cefepime, piperacillin-tazobactam. So most of them were talking about 3 to 4 hours of continuous infusion in those drugs.
Yeah. Wonderful. I have a question for you, Dr. Nada. When we talk about population pharmacokinetic models, in your practice in KFMC, I know you maybe 2 years back you moved to EPIC, etc. So, is there any specific computer-based algorithm or dosing pharmacokinetic model for antibiotics you use?
Sorry, can you say this again?
So, I mean, for antibiotics in the ICU, is there any like computer-based pharmacokinetic model for dosing antibiotics in specifically in critically ill patients?
Mm-hmm. Well, in adult ICU, we've been using like an institution-based Excel sheet that we have done for dosing vancomycin using AUC over MIC, but it's still under under examination and validation. It's always challenging when you do those institutional-based Excel sheets, because you need to validate it through different occasions, different patient population, different renal function. So validation is always a challenge when you are doing those institutional based agents. So for me, I usually prefer specific patient calculation, pharmacokinetic calculation, when we're talking about amikacin, vancomycin. Still, I cannot say that we had a validated Excel sheet or tool that I've used during my practice on a daily basis. Yeah.
I see. But maybe, as you said in your second to last slide, that AI will be
I'll take over, I'm sure. Yeah.
Yeah. So the more we feed information into an AI model in ICU, maybe we can get more accurate results with time, because in the beginning maybe it will give some mistakes, but as you correct it as a human input, that will make it accurate with time, I guess.
Absolutely. This is the future now.
Inshallah. Great. So, Dr. Nada, we have another question from anonymous attendee, not mention their name. So what is your advice? Because you deal with patients on ECMO or CRRT, and you lecture many students and many residents on this. So what advice can you give someone who is still naive in this area? What references they can look at? What guide you can offer to them to follow while they see a patient on ECMO or CRRT?
Absolutely. It's a huge and very interesting thing to look into ECMO and CRRT, and still it's not clear and not black and white, because if you look into the data for ECMO patients, you can see that at the beginning of having ECMO machines, we've been using higher doses of meropenem, vancomycin, and different, especially when we're talking about like even lipophilic or even hydrophilic drugs, because of the increased volume of distribution with ECMO machine. But now, with improving our machines, the ECMO machines, the oxygenator, the tubing, also with doing more pharmacokinetic research, we are seeing that we can see that those doses were a little bit extra, or the new machines will not requiring that truly higher doses of ECMO and ECMO. So having a look every time I have a patient on ECMO and looking into the recent research or publication is always important. Also, the clinical response, especially now when we're using ceftazidime, avibactam in patients with ECMO. For sure, I don't have any evidence. So clinical cure, microbiological eradication is my indicator to see if it was an appropriate dosing or if I would need to push for higher doses. But I would always advise to always go and look into drug references like Lexicom, Stanford. They have always sections for an ECMO and CRRT, looking into the different published research to have the optimal based on your patient population. But this is always an interesting area to look for.
Yeah, definitely agree. Okay, we have a question also on, okay, now if you use vancomycin continuous infusion in your institution, Dr. Nada, and you have a patient who is on intermittent and you want to shift to continuous, what would be the best strategy? Is there any dosing, conversion, any factor you need to multiply with, or any considerations here?
I would not use vancomycin continuous infusion. So the data does not really support continuous infusion of vancomycin. The opposite was shown that continuous infusion of vancomycin increases the risk of nephrotoxicity. So with this results, the data is very much against using continuous infusion with vancomycin. And would always go with intermittent over 30 to 1 hour infusion.
Exactly. Like what we do also in my institution, the same. Okay, Dr. Ala Thabit is asking, she just want to clarify with you regarding when you said about colistin. So the more renal impairment we have, so the creatinine clearance is going down, the higher the conversion from prodrug to the active. Is that correct?
Yes. Yeah, that's right.
And this will result in more accumulation and more nephrotoxicity, probably?
Yes.
Okay, that's good. So perfect. And I mean, if we keep, mashallah, we are receiving more than 30 questions. But for the sake of time, I'll take only one more question. And you know, we promised that we will send the other question to Dr. Nada so we can reply that.
Absolutely. Please feel free to get in touch, and I'll be more than happy to help.
Inshallah. So Dr. Nada, last question from Abir Al-Anazi. So when you see patients with augmented renal clearance, what would be different in your dosing of antibiotics?
So although augmented renal function is not very common, but it can always happen. So we're defining augmented renal function of creatinine clearance more than 150 ml per minute. And when we are having this polyuria or increased renal function or clearance of drug, we need to consider increasing the doses on those patients. And if you look into also drug references, you can see that most of those references are pushing to use higher doses with patients with augmented renal function in ICU patients. So those also very interesting patient population that they require higher doses as well. Yeah.
Excellent. Thank you very much, Dr. Nada, for your time. We really appreciate your, again, insightful presentation and this engaging Q&A session. We thank you for being with us.
Thank you. And I really thank you for the opportunity to present at the IVPN, and hope to see more interesting presentations through the critical care PSN as well.
Inshallah, Dr. Nada. Thank you so much for your support. And inshallah, we thank everyone who joined us today. We had more than 150 attendees, mashallah. And we encourage everyone to also sign up for our next webinar next week, March 24th, where we will be talking about the optimal time to resume anticoagulation after ischemic stroke. So please stay tuned, and thank you for everyone who joined us. And we encourage you also to sign and to register for the IVPN-Critical Care Listserv membership. It's for free, and you will be able to get always educational content and opportunities for your professional growth. Thank you very much, and have a good evening, everyone.
Thank you so much.
Assalamu alaikum.